Good evening, everyone, and welcome to the December 2022 NATS Chat. I'm Kari Ragan, moderator of NATS Chats, and I'm thrilled to be here tonight with Dr. Neel Bhatt from the University of Washington Laryngology program. And so thank you, Dr. Bhatt, for being here with us.
Thank you. Thank you for having me.
I'm lucky to be working in affiliation with Dr. Bhatt since he's come to the UW a few years ago. So I'm thrilled to have him here to be able to watch his presentation and ask questions. Before we begin, I want to just give a friendly reminder from the NATS executive office staff that it's renewal time, membership renewal time, and we're very appreciative of everyone who is renewed already, and we encourage everyone else to do so as soon as they can. NATS even offers auto-renewed signups. All you need to do is visit your member home, pay@nats.org, and you'll find all of this there. If you need any help, the office staff can help, and you can call them tomorrow during business hours or email at membership@nats.org. If you're not a member, we'd love to have you join us in 2023, and you can learn more at nats.org. And myself and Alan Henderson and other leaders in the NATS community would be so happy to speak with anybody who is considering joining. So there is my little promo for NATS tonight. So we are going to speak with Dr. Bhatt tonight about taking a look into the future, research in laryngology and voice. And before we do that, I want to just ask you a little bit about your background. I call it Beyond the Bio. A little bit about what made you interested in working with singers who are such a special group of people. I know we can provide interesting challenges, but what is in your background that led you to do this work?
Sure. Well, first of all, thank you, Dr. Ragan and the NATS organization for having me. This is a real privilege to be able to speak with you all. You know, I think working with singers is one of the biggest joys that I have as a physician, working collaboratively with speech pathologists, going back and forth on diagnoses, and it's really where art meets medicine. There's a lot of challenges, and personally, I'm not a singer. I have a lot of appreciation for music. Grew up playing piano and guitar and things like that, but I think it's okay. You know, I keep my MD hat on and really approach it as a physician, and you know, I can say very, very authoritatively that for me, there's nothing better than working with singers. It's energizing, it gives a lot of joy, and you know, at University of Washington, we have the opportunity to see performers, and it's a really wonderful part of my job.
You know, when I first started working on a team, I remember one of the most surprising things is that the medicine was not black and white. The diagnosis is not black and white. And even today, we talked off screen about shared clients that it's taken a bit to get clear on what the diagnosis is. That was fascinating to me. I assumed medicine had more clear boundaries or answers for us.
Yeah, and I think that you hit the nail on the head. I think as a physician, especially in this world, it's really important, two things. One, to have a lot of humility and accept that we don't always know the right answer. We'll get there, but we just go with what we think is the best. And if we're wrong, we have to be able to pivot. I think the second thing is to really listen to the patient, because ultimately, you know, a lot of my previous mentors have said they'll tell you the answer. It's just you have to really decipher through some of the noise and figure out what's important. So, but yes, I think your point is very well taken. There's so much we don't know. There's a lot we do know, but there's so much we don't know. And hopefully this talk will highlight some of the really exciting areas of ongoing thought and research.
I love that. Well, I know you have a wonderful presentation, so that's let's jump right into that.
All right. Hopefully this is clear.
Yes, I see it.
All right. Well, once again, my name is Neel Bhatt, coming from the University of Washington in the Department of Otolaryngology. I also work in the performing voice clinic along with Julie Rosenzweig, one of our lead speech pathologists. And I'm going to talk to you a little bit about some of the important directions, research, challenges that we are working on, and hopefully some stimulating areas of discussion. So I wanted to start with something that we look at every day in clinic, frequently assessing, and this is stroboscopy of the vocal folds. I know maybe it's a little choppy with the pictures, but what you can see is that we are assessing several things all at once. And we're looking at the vocal cords, vocal
Hang
folds.
on, Dr. Bhatt, I'm so sorry. Somebody
Yeah.
said they can't see the presentation. I can see it fine.
Okay.
Can we hold, can somebody else? I can see it. So maybe Brittany, it may be if you're, I can see it. All right, we are going to proceed. Brittany, maybe it's because you're on a phone. I'm not sure. I can see. All right, thank you, everyone. We're good. I'm so sorry for the interruption. Go ahead.
So we're looking at lots of different things at once. We're looking at the health of the mucosa, which is the lining of the vocal folds. We're looking at the movement of the vocal folds. We're looking at the vibration. So there's a lot of things we're processing all at once. And this is an example of a fairly healthy singer with good movement, good mucosa, good vibration. But it really highlights important aspect that we're simultaneously integrating a lot of pieces of information to make an assessment about someone's ability to speak, sing, and do the things they need to with their voice. So while I'm showing you an example of a really good laryngeal stroboscopy, I'm going to highlight some challenges that we face. Vocal scar, problems with the nerve, aging voice, and then just how we measure a lot of things. And hopefully these are springboards for some interesting discussion. So the first one I wanted to talk about was vocal scar. So what is scar? So if you noted in that video I showed you, you've got the body of the vocal folds. And the body is really what makes up the mass of the vocal folds. But as they come together, there is this gelatinous vibrating layer that's on top of it, sort of the cover to the vocal folds. And when air is expelled from the lungs and the vocal folds are in good position, it allows that vibration to occur. Unfortunately, for some individuals, whether it's trauma, phonotrauma, intubation injuries, a whole host of possible explanations, they can get scar. And in this picture, you see this whitish discoloration of the vocal folds. It's screen right, but it's the left vocal fold, and it's called scar. So essentially what happens is that vibrating surface gets tethered down to the understructure, ligament, and muscle, and so it's not allowed to freely vibrate. And as you can imagine, that treatment is really challenging. If you quickly went on PubMed to look for treatments for vocal fold scar, you'll see 30, 40, 50 possible treatments for it. But unfortunately, there isn't one treatment that has really everyone agrees on works all the time. So there's a high degree of variability in its success. And part of the reason I think that is because anytime you do anything instrumental to the vocal folds, and something I always tell patients is anytime we do a procedure, it's not a question of whether that will cause any scar, it will probably cause some. And so we're trying to balance the risks of a procedure with doing something that will hopefully help. And so what a lot of contemporary research has been focused on is the idea of injectables. The attractiveness of an injectable is that you can very atraumatically inject a substance under the lining of the vocal fold and hopefully either remodel the scar or add some substance that enhances the vocal fold vibration. One of the exciting injectables that I had a chance to work on in fellowship was the use of platelet-rich plasma. And probably many of you are very familiar with that. For a lot of different parts of the body, people will use this in orthopedic surgery, plastic surgery. And so right now we are at early clinical trials looking at the use of platelet-rich plasma as a series of injections to hopefully remodel scar. The rationale behind this being that the patient's own blood platelets can be extracted in a simple blood draw, spun down, and that material or the platelet-rich plasma can be extracted and injected. And early data suggests there may be some benefit. And right now, the one that we did at USC, University of Southern California, is 3 to 4 injections spaced out 1 month apart. And what we found is that for a lot of individuals, especially patient-reported outcome measure, there was a pretty good improvement in what patients were reporting. Peek Woo has also done this type of work, actually a larger case series, and this are the results that they've had, a higher number of patients that they've reported. And they've done some high-speed video imaging as well to corroborate what patients are experiencing with the enhanced vibration. And so for a lot of individuals, this has been a really nice, less traumatic way to hopefully remodel some of the scar. But ongoing work on this is really important. Other groups have looked at other growth factors, including basic fibroblast growth factor. And Hirano and colleagues have also done this type of injection in a very similar way. One of the challenges, though, with this type of injection is we don't know the long-term durability of this treatment. And it's one thing if patients are experiencing some benefit for 2-3 months, maybe while they're getting the growth factors injected or the platelet-rich plasma, but it's hard to know that this will sustain itself 3 months from now, 8 months, 2 years from now. And so a lot of people think that this material may have a short benefit, but it's unclear if this will remodel the lamina propria or the lining of the vocal folds for a long-term effect. And that's one of the challenges with these injectables is there's a lot of enthusiasm. You'll see a lot of case studies with a long series of patients, but very few studies that have compared placebo like saline to these types of injectables. So there aren't very many controlled studies. This is an excellent starting point. We need some of this preliminary data to power future studies, but I think there's an opportunity to study this in a more rigorous way. And again, these are high-speed video imaging looking at some of the vibration of the vocal folds. And you can see in the top pictures, or the top series of pictures, despite good lung support, the vocal folds are never able to fully close. The mucosal wave excursion closure is never enough. But after a series of injections of this basic fibroblast growth factor, you're able to get full closure, something that we look at very closely. So the take-home point is that injectables may have an important role in treating vocal scar. And as I alluded to earlier, doing a surgery where we cut the vocal fold, lift up the vocal fold lining, remove the scar, and then redrape it, that sounds good in theory, but the whole process of making an incision on the vocal fold is going to cause some scar to begin with. So that's why injectables are particularly exciting and attractive, because you're minimizing that sort of risk that is inherent with phonomicrosurgery. Preliminary animal studies show that the histopathologic improvement is there, and there may be some role in limiting scar at the time of injury. So for example, if someone was intubated for a long period of time for an underlying illness, maybe there's a preventative role to inject this material so that vocal cord scar doesn't happen in the first place. And again, like I said, the long-term efficacy is missing, and that I think is a real opportunity to study this these types of injectables. And it's currently happening. Longer studies, 1 year, 2 year outcome measures. So the next big area I wanted to talk about is nerve injury. And as many of you know, the nerves that control the vocal folds, at least the motion of the vocal folds, opening, closing, are chiefly done by the recurrent laryngeal nerve. And the reason that nerve is really interesting is because unlike a lot of parts of the body, the nerve is taking the path of the shortest distance from the brain to the target muscle. The recurrent nerve doesn't do that. It will go all the way into the chest, loop back up in the tracheo-esophageal groove, and then get into the larynx, and then innervate the vocal fold muscles. And because of, as you can imagine, brain surgery, neck surgery, chest surgery, intubation, viral illness, it has the opportunity to be injured where it's either paralyzed, where it's not moving, or paretic, where it's moving, but not a lot. And we see individuals with subtle voice changes from subtle changes in the motion or the movement of the vocal fold. And like I said, the nerve injury can happen for a lot of reasons. And one of our important jobs as physicians seeing new changes to the vocal fold motion is to really put our detective hats on and figure out where is the problem. And it's not so much just to treat the problem. We have to really look at why did this problem happen in the first place. And sometimes we pick up pathology from the thyroid gland or the chest or other areas that can be sometimes not known by the patient. And ultimately, when we see paralysis or the vocal fold is not moving at all, or paresis weakness, we have a lot of opportunities to treat this. But it's really restoring the valving of the vocal folds. And what I mean by that is we're restoring the ability for the moving vocal fold to touch in an optimal configuration so that the individual can continue to get voice. And treatments are designed to restore this function, but as you can imagine, before the vocal fold was doing a lot of things, opening, closing, had a lot of dynamic control, and how to fix that in a way to restore the underlying or baseline function is a big challenge. So when the nerve gets injured, there are a lot of researchers, including me, who are working on things to enhance the nerve recovery. So what can we do to promote those axons that are injured to get to the target muscle so that hopefully we can restore the motion, opening, closing, all the things that the nerve was doing? And one of the exciting areas is the use of muscle progenitor cells, which is a type of stem cell that may be able to inject into the vocal cord at the time of injury to enhance the axons to recover. And preliminary work, some of the things I've been involved in and other groups, Stacy Hallam at Indiana University, for example, have been using these types of motor end plate enhanced stem cells to promote the recovery of the axons. And in some animal models, there's very promising results. And if you can enhance nerve recovery, then perhaps the long-term consequences of having a nerve injury are minimized, which is an exciting area to be part of. Other folks have looked at actually reconstructing partial areas of tissue engineering of part of the larynx as acting as an implant. And so for individuals who have volume loss because of nerve injury, or some other type of injury where part of the vocal fold is no longer functioning in the way it should, reconstructing part of it is an exciting area that's still under a lot of work and investigation. And the last thing I'll mention is sometimes the nerve recovers in a way that you don't necessarily want it to recover. And what I mean by that is a concept called synkinesis, where the axons or the nerve fibers that are supposed to close the vocal folds, unfortunately, when they recover, get sent to muscles that open the vocal folds. And for a lot of individuals with very subtle or dramatic nerve injury, that can be a problem because sure, the nerve's recovered, but the signal is crisscrossed. And for a lot of researchers, this idea of selectively blocking the axons from even approaching the opening muscles is an exciting opportunity to enhance or shunt all the recovery to the closing muscles. And so with stem cells, tissue engineering, or neurotoxins actually to block some abductor recovery, there are some really cool therapeutic options, I think, that are on the horizon that I think have a real opportunity to shape patients after nerve injury to really get them as good of a result as possible.
Before you move on to the next, I'd love to just ask about the injectable. Oftentimes, do you find that people wait beyond this 3-month time when they're maybe hoarse, they don't realize maybe they had a upper respiratory infection that ended up taking, impacting the nerve, that's impacting the voice, and they don't go in. They think it's just hoarse and it's taking a long time.
Yeah, that's excellent point, very thoughtful point, and you're exactly right, and that is a big challenge. We've looked at the time to presentation in our very tertiary care center, and we rarely see individuals after nerve injury unless it's clear the surgeon knows that the nerve had to be cut. But I would say at minimum it's 3 months, and so you're absolutely right. The ability to shape nerve recovery is hindered by current practice patterns. And yeah, I think that is a certain challenge, and we really focus on educating primary care physicians and referring otolaryngologists about the fact that if someone has dysphonia or problems with their voice that last longer than 2 weeks, depending on a host of potential patient factors, not a bad idea to send them our way sooner, because maybe there are some opportunities to consider things to enhance recovery. Hope that's clear.
Yes, there's a question about this, so let's stick here for a minute. I had a question about synkinetic reinnervation. Can behavioral treatment rewire the brain to recover the original function?
Wonderful question. I think that's controversial. Some of speech pathology colleagues may have a different opinion on that. I think it's possible. I think that the ability to control how you use your voice, breath, I think is modifiable. And so it may not be purely changing the biochemistry of the axons or making the axons change where they're innervating, but I think how you control your voice, breathing, all those things can be modified. So I think the answer is yes, and I've seen good results from working with speech pathologists on a few of those things.
Thank you.
All right. And another area that I also think has some opportunity here is the use of implantable laryngeal pacing devices. So this is a little bit more for people with both vocal cords that are not moving, but there may be some opportunity for individuals with one vocal fold that isn't moving very well. In our world, there's an Inspire device that for people with obstructive sleep apnea, for some people, they can get this implanted device that actually moves the tongue timed with respirations. It's currently being used, and it basically juts the tongue out of the way during inspiration so that you don't get that tongue base obstruction that a lot of people do get with sleep apnea. And so there are researchers who are looking at, can we use the same type of technology to electrically stimulate the nerve so the vocal fold moves when you want it to? So for bilateral vocal fold paralysis, the real issue is getting the vocal folds out of the way. So when you take a deep breath, stimulating the opening axons so the vocal folds open up. For other people with one vocal fold that isn't moving, you're, like I said, trying to get the valving. And so just like a cochlear implant, for example, that could be programmed, I think that there's a real opportunity to have this type of device that could do things that you wanted the vocal folds to do in a programmed fashion, whether it's timed to respirations or some other external factors. Right now, this has been done in some animal studies and also in some limited human studies, and early promising results. And I think to be seen how much this integrates in clinical practice.
Wow.
So one of the last areas I want to touch on is the aging voice. And this is an area of my interest personally in research. And, you know, when we look at the larynx of individuals that, you know, a little older, it's hard to always know what their vocal cords look like in the first place. But we see some clear characteristics where the vocal folds have a bowed or hollowed appearance, where rather than completely touching, they have this spindle-shaped gap. You can see that with the dark air between the vocal folds. They often have to use a lot of accessory muscles or supraglottic muscles to really get the vocal folds together. And it's a challenging thing to treat. And one of the other problems is that we see a lot of patients that have significant others with hearing problems, and it compounds the communication challenges of being able to speak loudly, people hearing, and then for singers, the subtle changes that may happen as individuals age. One of the problems is, though, that the mechanism by which age-related vocal atrophy occurs is very poorly understood. And personally, I'll add that I think it's unpredictable. We'll see individuals who are in their 70s, 80s, who really don't show any changes to the vocal folds, and other people, you know, we'll see some, not to generalize, but very quiet individuals, you know, in their 30s and 40s who have these very hollowed looking vocal folds. And is it a use-disuse issue? What causes this? And this is an area of my research trying to figure this out. And as a general framework, we think that aging causes changes to the neurophysiology, the shape of the vocal folds, and if we were to study it, the histology of the vocal folds. And all of those things affect how the vocal folds and the larynx overall functions. We looked at the current state of the literature, looking at studies, looking at age-related vocal atrophy. And there are only about 7 or 8 high quality studies, and they're all over the place in terms of their outcome measures. And so this is an area that really requires a lot more thoughtful investigation. People are trying lots of different voice therapy, voice exercises, a lot of injectables, thyroplasty, which is an implant. There's a lot of things out there, but similar to vocal fold scar, no one treatment that seems to predominate or overtake the rest. And so there's a lot of opportunity for new innovative treatments. And Dr. Aaron Johnson, a speech pathologist researcher, has developed an animal model actually to study the effects of social isolation, and has measured I think it's in rodents and rats, looking at ultrasonic vocalizations, and has developed a really cool model to study how animals age with social isolation, how that leads to deterioration in vocal quality, and that those animals can be somewhat rescued by cohabitation, increasing vocal demands, and almost like intensive voice therapy changes some of the product or the ultrasonic vocalizations, as well as the histologic findings with neuromuscular junctions, which is really interesting and exciting way to study this. And other people are looking at autologous cultured fibroblasts. This is one of the newer studies looking at vocal fold scar and atrophy, basically plumping up the vocal folds with this autologous material, meaning derived from someone's body, and trying to improve pliability, the plumpness of the vocal folds. Right now, a lot of our treatments are not always great, and it's somewhat unpredictable. We can add bulk to the vocal fold, but once we add bulk to the vocal fold, some of the vibratory characteristics are changed too. And so some more nuanced treatments that hopefully has long-term durability, I think would be really great for some individuals who have this vocal atrophy. This is just a picture to show what vocal folds can look like. The A shows very nice, big vocal folds. They come together, very straight closure. The image on the right shows this bowed appearance, and despite the patient's best efforts to get the vocal folds to close, it's not always possible. And so the last topic I want to talk to you about is how to measure this, and this is an area of my interest. For a lot of people with carpal tunnel injury or spinal cord injury, there's something called nerve conduction studies, and that is electrically stimulating the nerve and measuring the action potential in the muscle. And different axons travel at different speed. So whenever you stimulate the nerve, you can get this temporal dispersion. And different axons will summate at different times, and you get this compound motor action potential. And so what I'm interested in looking at is, can we use this nerve conduction study and compound motor action potential to diagnose a lot of the peripheral nerve injuries, whether this is age-related vocal atrophy, or this is a weakness, or this is tremor, or this is some other pathology, and use this in a more objective way. Because one of the challenges in our field, laryngology, speech pathology, is that things are very qualitative. And so we're looking at the strobe, we're going back and forth about what we're seeing, but unlike a blood sugar or a blood pressure, which we have clear numbers for, cutoffs, ways to really know whether things are getting better or worse, unfortunately, with some of our assessments, it's highly dependent on qualitative measures, which can have bias, can have problems. And so I'm excited about the potential use of these types of things. And building on Dr. Aaron Johnson's work, we're also using a rat model looking at aged vocal folds. And we're seeing some electrodiagnostic, electrophysiologic changes that happen with aging, something that we're continuing to investigate why that's happening. And so I'm excited to report that, hopefully in the coming years, about what's the mechanism about why the vocal folds begin to atrophy. And the real last thing I'll finish on is one of the surgeries that we do is a total laryngectomy. So very different than a lot of the things that we've talked about. But for people with cancer, advanced cancer, the larynx is often, unfortunately, needing to be removed in a way to control cancer. And while it's a devastating surgery and a lot of factors that go into the decision making, as researchers, we have the opportunity to study these muscles, nerves in a population of individuals that are oftentimes aged 60s, 70s, 80s in age, and so we can look at what's happening to the nerve, what's happening to the muscle. And so this is a really nice parallel model to study. On one hand, we have the rats, and on the other hand, we have the human, and really looking at what's the overlap. And so it's a really exciting way to translate some of the very basic animal stuff into humans, and hopefully we'll get some more information about that. And so, ultimately, it's a matter of measuring. It's a matter of coming up with new treatments. And I think it's really important that we study this in a very rigorous and thoughtful way. And there's a lot of opportunities in our field, laryngology. And so excited to be a part of it. And I think hopefully in the years to come, some very cool treatments that will hopefully revolutionize or really enhance patients' quality of life with voice-related issues. So happy to chat more, answer any questions anybody has.
So fascinating, and thank you for being able to present it in a way that we can understand it. I mean, that's a gift for an MD and a scientist to be able to do, so thank you. I had one question, or two actually, on the aging. I mentioned it off camera, but in our world, we talk a lot about hormones and the impact on the singing voice. How How much is that being looked at from your perspective as you're considering the aging voice?
Yeah, that's a very good question. And there are people who believe very strongly in a whole host of different hormones that could be helpful. It is, as far as I know, not being investigated in a very controlled or thoughtful way. So you have a lot of people who will report their findings with 10 people who got this hormone replacement, and it's hard to know whether it's helpful. And I think most importantly, there are some patients maybe with certain deficiencies who do get better from it, but maybe it doesn't apply to the average person. And so that's why I'm excited to really get to the nuts and bolts as to what's happening with age-related atrophy, so that if we can really understand the precise mechanism about why the muscles are atrophying, then perhaps we can more confidently say, okay, well, this makes sense. You know, hormone replacement makes sense. So I hope that answers your question.
It does. Do you think we'll get to a place where it's like going to a plastic surgeon or, going to a dermatologist for your filler that will, be comfortable with that, with filling our vocal folds up as we age?
That's a great thought. I think we're getting there. I'm relatively new to the field, but looking back historically, vocal fold injections were done with Teflon in the operating room. Patient is asleep, big ordeal. Teflon, we later found out, was not a good injectable. It caused a lot of problems in some patients. The point I'm making, though, in 20, 30 years, the field has changed so much that now I do about 90% of my injections in the clinic. So the patient is awake. We anesthetize the larynx, and it's such an advantage to be able to do that. We can, in real time, judge. The patient doesn't need to be fasting. Risks of anesthesia are dramatically minimized. And so to keep that extrapolation going, I think you have a great point. We just get more confident and comfortable with in-office procedures, and we're willing to try some things. And these are discussions that we have all the time in clinic. Do you want to try something? So you're looking to the future. I think it's possible in 20, 30 years that we think of it more like a routine maintenance as opposed to some big procedure.
Yeah, oh, that's great. Julie Rosenzweig, who is on tonight and is one of Dr. Bhatt's speech language pathologists and with whom I collaborate every day, says, is there one area of research that you anticipate will be the most useful for singers? Great question, Julie. Thank you.
Yeah, I think when it comes to singers in specifically, I don't know, maybe I'm biased, but I think that, again, I think the changes with aging, the unpredictable changes with aging, I think are a big area. When I do phonomicrosurgery on someone who doesn't exhibit changes of age-related atrophy, and that doesn't mean that they're young, but they could be older and still not have those changes, the results from the surgery are better. It's just better. They just have much more capacity for vibration. But when you have a vocal lesion, and I'm talking like a polyp, cyst, a nodule on the vocal folds, and vocal atrophy, your likelihood of success, you really have to be a lot more careful in those settings. And I found for a lot of patients, the road to recovery is a little longer. It takes a lot more help. We lean very heavily on our speech language pathology partners. And so I might be biased because this is my area of research, but I do find that age-related atrophy is a big thing. And last point I'll make on that is we have an inherent bias, I think, as physicians, that age-related changes are expected, that we just accept it, and patients also have this feeling like, well, maybe I'm just changing, I'm getting older. And that's fine to have that, but for a lot of other areas of the body, we don't have that same bias. We work actively You know, we think about like if someone has a knee problem, it's not we say, well, it's just aging. We're just not going to work on it. You know, we're aggressive about coming up with treatments. So I think the same thing should be applied to the voice and the larynx.
I love that. Thank you. Is scarring still, I always think of when I get a client with this, comes to me with a scarring diagnosis, is that still one of the, oh, and we can stop sharing screen. I forgot about that. Is that still one of the most challenging in diagnoses?
I think it is one of the most challenging things, but I do think that for people who have used their vocal folds, you know, singers or teachers or lawyers, you may not see scar, but you'll see some things that are not perfect. And I always emphasize that just because we see a little something that might be scar, that may not be impacting your vocal fold vibration at all. And so I really try to emphasize the importance of the function of the vocal folds, the function of voice and larynx, more than the pictures. So when I'm with patients, I intentionally will try to turn the screen off and focus more on the, you know, what we're doing, what the product is. And so for a lot of people, they see, oh, I have scar, it's over. You know, my career or my profession. And for a lot of people, you can very nicely coexist with a little bit of scar, and you can still meet the goals that you want. So to answer your question, absolutely, scar is a challenging thing. We don't want it, but scant amount of scar, especially if it's not on the vibrating surface of the vocal fold, may not have any clinical consequence to your voice and can be a bit of a red herring. You see it and it causes anxiety, fear, and to be perfectly honest, it may not be affecting your voice at all.
Interesting. We've got some great questions coming in. Dr. Bhatt, do you have anything else on the presentation to share, or do we want to move out of that? And they
Sure,
can.
let me know if I can, do I need to do anything on my end?
Yes, just hit stop showing screen.
Okay, got it.
There we go. And there, now people can see you better. All right, so some great questions. Margaret asks, would you please comment on thyroplasty when several types of injectables do not improve sound? Is that a dangerous surgery with possible problems that may occur, and what are some of the risks?
Great question. So as a very simple framework, just for everyone, in order to get the valving better so that the vocal folds touch better, we have some tools. We have speech therapy to really enhance just your overall efficiency. But then when it comes to procedures, we have two big options. One is an injectable, so similar to what I showed you, we add bulk to the vocal fold. The second is a thyroplasty. So from the outside, we make an incision, drill through the larynx or the thyroid cartilage, and customize a type of implant to keep the vocal fold in a good position. So they're not really apples, it's not comparing apples to apples, because the injectable, unfortunately, it's temporary. Most of them last, 3 to 6 months. Some are a little longer, but we think of them more as temporary things. The thyroplasty is more permanent. The thyroplasty can also be customized in a way. So for a lot of individuals, the improvement with the thyroplasty can overshadow the improvement with an injectable, because you're basically adding the material in, but you have you don't have as much control over where that material goes. And so as a very simple framework, I often think if patients get benefit from the injection, then let's do the thyroplasty or the more permanent option. But there are times where people don't get benefit from the injection, but I still think there is value in going to the operating room to really customize an implant that I think is going to help them. In terms of risks of the surgery, one great thing about the thyroplasty is that the patient is generally awake, or at least in a mild sedation, because we want to wake the patient up in the middle of the surgery to really test out the implant, making sure that we're doing the best job we can to get the best product. And so unlike some surgeries where you're under general anesthesia, breathing tube, in some ways the surgery is a little bit safer because you don't have the risks of general anesthesia.
Great answers. I have had the privilege in the last 3 years of probably 8 thyroplasty cases that I've got to help on the rehab part for singing. And what's been surprising to me is I always thought, I can't wait because it's going to be the magic bullet and this magical fix of whatever vocal challenge they're having. And I would say that hasn't, I would say they notice less effortfulness. I hear it slightly and I hear some improvement, but it's not a magic fix. But all of the clients, except perhaps one, definitely felt less effortfulness and were thrilled. I mean, just in the first singing session back, tears, because they could feel the difference. So it's, again, that's science. You would think it's a magic bullet, but it's an interesting process, isn't it?
Right. And that's a fantastic point. You know, if thyroplasty was perfect and it could restore everything, well, then kind of our research work is somewhat done. You know, we've sort of figured it out, but we're not there. And it's a lot of times it's a big block of like a silicone type of block that we're putting in, and it doesn't check off all the boxes. So there's still opportunity for innovation, and I think that keeps us going to figure out better treatments.
Well, and Ken Bozeman, who is on and shares this with people, so it says he chose to have the bilateral thyroplasty with Robert Bastian. He said, while I did not expect it to revive my singing, it did significantly improve my speaking and enabled brief demonstrations for lessons. So thank you, Ken. That's a really important point because my singers definitely report speaking improvement. It seems like the singing is a little more variable. The results. Is that kind of what you anticipate?
I agree, you know, and speaking is one thing. Singing a lot of times has a higher intensity, and for singing, getting good volume intensity, I think if you make a thyroplasty pyramid of your check boxes you're trying to do, I think loud intensity is really, you know, you hit the surgery out of the park, if that makes sense. And for singing, getting that high intensity, I think makes the surgery really challenging. And so, yes, I agree with you. I think for singing, I can see how that would be the little less predictable than speaking voice.
Well, and Julie just typed in, thank you, Julie, and makes this point. I always forget this. The implant doesn't stretch with highs, with the higher nodes. So that the implant, I don't know if you use Gore-Tex or what is the preferred now, but it does not have a flexibility or a pliability like a vocal fold would, correct?
Right, and exactly. And so for age-related atrophy, where you have sort of thinner vocal folds, the bluntness of the implant could affect the vibration. So for bilateral implants, like we were discussing, for mobile or non-paralytic vocal folds, I will generally use Gore-Tex because Gore-Tex as a material is a little more pliable than the silastic or the silicone type blocks.
And do patients, thank you, Emily Simmons, for this question. Do patients ever want a thyroplasty revision or removal? And would removal cause vocal fold scarring?
Very good question. It does happen. And so when, in terms of the wanting to get it out or revise it. And I think for every surgeon, it is built into the calculation that a certain percentage of them, despite our best efforts, we're just not as thrilled as we want to be. And we think that based on the in-office stroboscopy, we can get better. And so there are times where we'll revise it or another surgeon's implant. Fortunately, with the thyroplasty, where it's positioned, it's underneath the lining and it's pushing the muscle. So it doesn't have the opportunity to touch any of the lining. And so vocal scar is not something I would expect after a thyroplasty.
Okay. Great, some great questions. Has Arthur Levy asks, has anything other than Restylane being used for partial vocal cord paresis that is more up to date and more effective?
Yeah, Restylane is a great material because the viscoelastic properties of hyaluronic acid, it's very soft, very pliable. Um, Other people will report fat, so harvesting fat from someone, from the body, processing that and injecting that. The advantage of fat is it's even more pliable and maybe even better. One of the problems is that you need a donor site, so does it require a second incision or an incision rather? And there's some unpredictability with the material. It can go away quickly or it can stick around for a long period of time. So for a lot of people, fat has been a big part of people's practice, and for others, it's not. There are some other materials, carboxymethylcellulose, that maybe even is shorter. On the other spectrum, there's some calcium hydroxylapatite or Prolarin Plus, which is a very kind of firm material. And other people are looking at two kind of experimental products. One is Silk. So Silk Voice is a product that is in the process of becoming a commercially available product, probably will be in the coming years. People tout that that has better properties, softer, and may have a longer mechanism of action than Restylane, which unfortunately is 2 to 6 months. There's another product that's it's a kind of an adipose fat matrix that might enhance some fat regeneration into the vocal folds. But Silk Voice, I think, is the more promising of the two. And so to answer your question, I think there are some really good injectables on the horizon that achieve those two really important factors: good viscoelastic properties, and two, sticking with, not going away so quickly. And Silk Voice may be one of those products.
Interesting. I'd love to ask, you didn't present on it, but about beta blockers. I have kind of a two-pronged question. One, singers that take beta blockers or interested in taking beta blockers because of high anxiety and nervousness when performing. And then secondary to that, as I mentioned off camera, we have a client that we share that has mild tremor, and that has been prescribed. So I'm curious about how that works with the tremor.
Yeah, so propranolol has been used for essential tremor for quite a while. And the mechanism by why that works for essential tremor, and I'm talking tremor of the hands or other parts of the body, truncal tremor or extremity tremor, mechanism is not, I think, clearly worked out. It was an observed byproduct of this blood pressure medication. But it's a nice side effect, if you could call it a side effect, in that it helps people with tremor. Now, for the vocal folds, this is fascinating because is essential vocal tremor, is it the same pathology or pathophysiology as the other types of tremor? And it seems like it might be. So essentially, instead of having tremor in your hand, you have tremor in the larynx. And there was a study by Michael John's group when he was at Emory, and they were comparing propranolol, which is the beta blocker, with Botox injections, which is considered really the gold standard for tremor. And what they found is pretty comparable results between the propranolol and the Botox. But the advantage of the propranolol, is that it's not an injection. You can take it every day. You could titrate your dose. You know, if you're not singing, you may not want to take it. But the problem with Botox is it's a procedure. You have to get, you know, there are some breathy periods right after the injection where your voice may not be exactly where you want it to be, and figuring out exactly which muscles to inject is a challenge. And so for me, I think it's been a really nice tool when we don't know whether it's tremor or something else. And you know, for a lot of people, it's like, how could you not know it's tremor? But sometimes we see tremulousness, or we see some shaking of the vocal folds, but not that real nice rhythmic pattern that you see with tremor. And we don't know, is that vocal fold weakness or is that a tremor? And sometimes we're wrong on that. And so propranolol is a nice medication generally pretty safe to see does the patient get better from this, and that might clue us in of the underlying diagnosis.
Okay, wonderful. Scott Kovacs has a great question, which is a perfect segue to where I wanted to take us as we come to the top of the hour. And that is, as the laryngologist, what do you want we voice teachers to know? Like, what is there any kind of multi-pronged question? Is there something you see in your office frequently that you think, boy, if more voice teachers and singers knew this, or yeah, just any bits of advice you would have for us as singers and teachers of singing?
Yeah, I think as a physician, you know, I think it really takes a real strong multidisciplinary approach, and that's with the singing teacher, speech pathologist, physician. You know, there can be other physicians involved, gastroenterology or pulmonology, and it takes a lot of combined cooperative effort to get to the finish line. And a lot of times patients feel like, I'm going to look at the vocal folds, diagnose the problem, do a real minor quick surgery, take this thing out, and then we're good. But there's a lot of buildup. There's a lot of post-surgical treatment care that's important. And I think it fits into this overall idea of trying to take out some of the catastrophe from what we see in the office. And for a lot of people, especially singers of all stages, you can sense nervousness, anxiety as they come to the clinic, because they already feel like they know what I'm going to see. They, you know, I have a vocal cord hemorrhage or I have nodules. I just know it. And most of the time they don't, fortunately. And even if they do, it's not the end of the world. There are so many things that we can do, work on, from therapy to procedures to time to medications, to get someone back to where they are. And I think, you know, our goal in the Performing Voice Clinic especially is to really ratchet down the anxiety, catastrophe, and really be as optimistic and rational. It's not just false optimism. That we'll get there. It may take some time. It may take a few visits. It may take some false starts and things like that, but we will get there. So, sorry, a little bit of a long-winded answer, but I think it's you know, taking out some of the anxiety from the visit, I think, is important, and taking it one step at a time is such an important way to look at overall.
And encouraging our singers to, I know it's easier for us in Seattle than other places, but encouraging them to have a baseline strobe,
right,
so that they know if something doesn't feel correct or amiss later on, they have this baseline, or if they're concerned, not to avoid it, like you said, but go ahead and go, and not to create catastrophe. That they'll be in good hands, and with the team, they can work through most of any challenge that comes up. So we're so grateful for all the laryngologists that collaborate with the singing community. So, and thank you so much. Thank you for your time tonight, Dr. Bhatt. So wonderful to hear you speak about all of these research that's going on.
Thank you. No, it was great and really awesome questions, and it's good to connect with you all. Thank you.
Thank you so much. Everyone have happy holidays as you go into the rest of December. The January NATS chat date, which will be with Marco Guzman, co-hosted with my colleague Lynn Maxfield. We're having to find a different date, and so stay tuned for when that will be. Keep your eye on Facebook, NATS chat page, and Intermezzo that comes through the NATS community on Tuesdays. Thank you everyone so much. Be well. Good night.